So I will begin by indicating that we're very fortunate to have our research supported by National Institute on Aging, but we also have support from the National and Local Alzheimer's Association and also Barnes Jewish Hospital Foundation. So I'm very appreciative to be here tonight to give back to you some of the research advances that the foundation has helped sponsor. We have a big program, the Knight Alzheimer's Disease Research Center, and we have 40 faculty, I think 85 staff, and we see over 900 research participants every year. So Alzheimer's disease, it's very much an illness that is associated with aging. I use the term associated deliberately. I don't think Alzheimer's disease is an age-related disease. Related means the older we get, the more likely we are to develop the disease, and if we get old enough, we all would have it. And I don't think that's true. I think it's related, it's associated with aging, but it's not the same thing as aging. And you know there are many people that you're aware of in their 80s and 90s who are perfectly fine. So it's not the same thing as aging, but obviously aging plays a role. And this illustrates that. So if at age 65, about 5% of the population has Alzheimer's disease, you can see it's really a dramatic, almost exponential rate of increase, so that for every 5 years of additional age, the frequency doubles. So it's 5% at 65, at 70 it's doubled up to 10%, 5 years later at 75, doubled again, up to 20%, and look at age 85, 50% of individuals. So clearly it's related to aging in some way, and we have a relentlessly aging society. So already in 2015, over $200 billion a year are spent on caring for Alzheimer patients. And as the population continues to grow, we will have many more people. I think it will bankrupt our healthcare system. Now, I want to say that individuals who are particularly aware of Alzheimer's disease are baby boomers, people born between 1946 and 1964. And do we have any baby boomers in the audience? A few, great. Now, I also would like to ask, do we have anyone in the audience who's born after 1964? Will you raise your hand and keep it up? Keep it up, because we baby boomers want to see who's going to be taking care of us. So Alzheimer's disease is a brain disorder. Ultimately, brain cells die. This is the first known Alzheimer patient. She was diagnosed in 1901, so a little more than 100 years ago. Almost certainly, people had Alzheimer's disease earlier in anyone who would live to an age that they would be vulnerable, but very few people did. So people didn't really recognize Alzheimer's disease. But she was seen in an insane asylum in Frankfurt, Germany. The story is she was brought to the insane asylum by her husband, and the admitting physician was a psychiatrist named Alois Alzheimer. And he took the history from the husband. She had a particularly aggressive form of the disease. At age 47, she began to develop forgetfulness. It was pretty subtle at first, but it gradually got worse. And as it got worse, she was less and less able to carry out her usual activities. So the husband had to support her and help her and eventually take over for her. She also got disoriented very easily and would tend to wander out of their apartment if she wasn't supervised, and he would spend a frantic period of time trying to find out where she was. So whenever he went out to do the things that she used to do, such as going to the market to purchase groceries, he would have to take her with him because he couldn't leave her alone safely in the apartment. And she developed something called a delusion. Now that's a false belief. She believed something that was not true, and no matter what he could do to try to tell her it wasn't true, she continued to believe it. She wouldn't be swayed. And her delusion was he was having affairs. So whenever he would interact with a shop lady at the market, she would have a fit. She would fly into jealous rage. And she particularly suspected a neighbor lady in their apartment, and it got to the point that she would be at all hours yelling terrible things about what the neighbor lady and her husband were doing, and it kept the whole building awake. So the husband had to bring her to the insane asylum where she lived at age 51 when she came in and died at age 55. Now, what Alzheimer did is he got her brain and he studied it under the microscope using new stains that were just available for him. It was a perfect storm and opportunity. And he found these lesions. These are the actual photomicrographs from the study of her brain that Professor Alzheimer prepared. And the first thing he found was something he called a miliary disorder, but we know now with more modern technology is something called a plaque. This is brain tissue, and a plaque. And within nerve cells, something called a tangle. And we still see the tangles today with these more modern techniques. So what these two processes mean, depicted by Alzheimer, is that the brain cells are dying. And we can see that the result of that here. Here's a half brain of someone who died with advanced Alzheimer's and half brain of someone who didn't, say, die with Alzheimer's. I'm going to have to change this because it says healthy brain and the person is dead, but they didn't have Alzheimer's. But you can see how shrunken this brain is and how wide the fluid spaces are in comparison with the healthy brain. Now, the study of these lesions that Professor Alzheimer depicted, we now know that the plaque is made up primarily of a protein in the brain called amyloid beta. That's the abbreviation for it. And the tangle is made up of another brain protein called tau, and I'll come back and talk about those. Now, there's an interesting update to this woman's story that has to do with her husband, who after she died was a widower. And about a year after she died, he remarried, and he married that neighbor lady. I think it was a coincidence, but so terminology. Here's what we talk about when we talk about Alzheimer's. It's a brain disorder that causes a loss of brain cells. It's progressive. It's a continuous process. We say it has two major stages: a clinically silent stage that we cannot detect, asymptomatic or preclinical before the diagnosis, and then a symptomatic phase. Now, when we say Alzheimer's, most people conjure up somebody who has the Alzheimer dementia, but we say that there's this pre-symptomatic or asymptomatic stage. I'll come back and talk about that. Symptomatic Alzheimer's disease is defined by intra-individual cognitive decline, begins very subtly, but always gets worse and always results in death. So people want to know, what is the relationship of Alzheimer's disease, this brain disorder, and the term dementia? So here's a definition of dementia: a decline in a person's memory and thinking abilities. So their cognition is declining from what it once was. And it's not simply a perceived decline. It has to be sufficient that the person's ability to carry out his daily or her daily life is affected. Now remember, I say it begins very subtly. So when the symptoms begin, the cognitive decline begins, the loss of everyday activities may be very difficult to detect. And it's very hard to pinpoint when dementia begins because it has this subtle, gradual onset. But just like that first Alzheimer case, eventually people increasingly lose the ability to carry out their usual activities, and they have to be supervised. As the disease progresses, they give up those activities. People have to do them for them, and eventually they give up even basic activities. At the end, they have to be dressed, they have to be bathed, they're incontinent, they can't swallow, and so they have to be total care. So it's a gradual process, but it interferes with everyday activities. So here's that term again, intra-individual change. So we can talk to somebody who knows the person, knows what they were like 5 years ago, 10 years ago, what their normal abilities were, and find out, has there been a change, and if so, is it affecting their daily life? So that's one way to detect it. Another way is to test the person's cognitive capabilities, do psychometric testing, and see how a person performs in relation to other people of the same age and education area. So I'm going to say that both of these are good, but I want to illustrate from our research volunteers 2 individuals and their test performance on our cognitive measures. So for your purpose on this scale, using all of our test measures together, a score of 0 indicates the average of our healthy people. So all of you, if you came in, we gave you the test and we put all the test scores together, the average would be 0. Now some people are really good, they're very bright or well educated, they score a standard deviation or even 2 standard deviations above normal. Some people aren't as good, they're a standard deviation or 2 standard deviations below. Well, I've picked 2 healthy people, at least they were healthy when they came in, a man here and a woman here. And if we had these test results only, we would say, well, the man is fine. He's scoring just like his peers do. And the woman we might be concerned about, because even though we think she's healthy, she's almost 2 standard deviations below the peers. So what happened to them? By the way, we assess people annually. So the next 2 times of assessment, the man declined pretty dramatically. He's now 4 standard deviations below the average. The woman still scores poorly, but there's no change. Okay? And this isn't the whole story, because I picked these 2 people to illustrate this. The man, at his beginning time, was one of our top performers, a retired CEO, well educated, and he stayed pretty stable for the first 6 times of assessments. Then here, boom, downhill slope. If we had tested him only here, we would have said he's normal compared to the others, but he's not normal compared to him. Does that make sense? Intra-individual cognitive decline. So even though we might say you score normally, it ain't normal for him. And the woman never changed. So she was stable. So when we ask family members, usually it's a spouse or an adult child, about an individual and are they having memory problems, it's a long, detailed interview, and it's not clinically useful for busy physicians. So we looked at the most informative questions that we ask of someone who knows the person well. Is there a change in these areas that's caused by memory and thinking difficulties? And here are the things we look for. Is the person repeating himself or herself more often? Are they forgetful? Do they miss appointments? Poor decision making. Maybe don't purchase things well, poor driving decisions. And by the way, about half of all people with mild Alzheimer's disease still are driving. Difficulty with financial affairs, forget to pay bills or pay them incorrectly. Difficulty operating appliances, get disoriented, decreased interest or ability to carry out usual activities and hobbies. And an overall question, do you think your husband has a problem with his memory or thinking? If you have 2 or more yes answers to this, 2 or more yes answers, the chance of having dementia is about 87%. Now this is just a screening tool, it's not a diagnostic tool, it doesn't tell us what causes it, but it can help busy physicians try to identify people who may need more in-depth assessment. So this is the course of Alzheimer's dementia. Now, I neglected to say something. My memory isn't so good. So I told you earlier, Alzheimer's disease is a brain disorder, and I told you about dementia. Alzheimer's disease, if a person has Alzheimer's disease in the brain and they continue to live, they all will develop dementia. So Alzheimer's dementia. But not everyone with dementia has Alzheimer's disease. So you can have dementia if the memory and thinking areas of the brain are affected by another disorder, say strokes. So strokes can cause dementia, okay? So everyone with Alzheimer's eventually will be demented, but not everyone with dementia has Alzheimer's. Is that clear? In late life, that was an odd statement. I was going to say late life, 65 and older. I'm 67, so really late life. In older age, Alzheimer's is by far the most common cause of dementia. All right, so Alzheimer's dementia, this is the course. It begins very gradually. This is normal. Look how subtly it begins at the beginning, at the start. Hard to tell what's going on, but it always gets worse. And this is the typical mild case of Alzheimer's dementia. So we've already talked about some of this. Almost always memory problems, ask questions that have already been answered, poor judgment. But the person still is doing their usual basic activities, still dressing, still shaving, still grooming hair, showering, all independent. And a matter of fact, to outside people, they act normal. They look normal. It's only the family that knows that there's been a change. And as I said, they may be out in the community independently, including driving an automobile. But it always gets worse. And as it gets worse, it moves into this moderate stage. And now people really are impaired so that even people who don't know them would identify that there's a problem. And now the person is not out in the community alone. If they go out to church or temple or wherever they're doing, they're always in the presence of a family member. They can't do it alone. And now their basic activities, they may still be doing it, but they need help. So they may be getting dressed, but someone's going to have to be there to make certain that they select the appropriate clothes for the occasion, or they don't put on two blouses, or don't put the trousers on inside out. And they may need reminders to brush their teeth. So there's some supervision now of even the most basic activities. At the end stage, I mentioned it's miserable. The whole course is miserable, but the end stage, person has lost awareness of the people that are closest to them. They don't know their family any longer, and they require total care. Everyone dies with Alzheimer's. So the total course of this phase is about 7 to 10 years. What are the risk factors for Alzheimer's disease? So one, we've already mentioned, is getting older. Number two is family history. And this is complicated. There are two rare forms of genetics that can cause Alzheimer's. The first is Down syndrome. Every person with Down syndrome, if they live to age 35 or beyond, gets Alzheimer's, 100%. 100%. We'll come back. If you have questions in the question and answer period, we can talk about this. There are also rare people with Alzheimer's disease who have in their family a gene mutation that causes the illness. And this is a form of the disease that if your parent has the mutation, your parent has a 50-50 chance of passing it on to you. If you get the mutation, you're going to get Alzheimer's disease also, 100%. And usually at a young age, usually in the 40s. If you don't inherit that mutation from your parent, you have no more risk of Alzheimer's than anyone else. But this is rare. Less than 1% of all people with Alzheimer's have a gene mutation. So this is the complicated part. We inherit from our parents genetic profiles. My parents turned out to be tall. I'm tall. My parents come from Northern Europe. I'm relatively pale-skinned. Okay? I was a redhead, and then, as Victor knows, we had children, and then so. But as a kid, my pale skin, being a redhead, I would get terribly sunburned because I have low pigmentation in my skin. That's a genetic trait. Now, did my genetic trait cause me to get sunburned? I had to go out in the sun, right? I'm at risk for getting sunburned because of my genes, but there's something else that has to trigger it. And that's why Alzheimer's tends to run in families, because families share these risk genes. They don't cause the disease, but they put us at increased risk. Does that make sense to people? So that's the most common cause of Alzheimer's. There are lots of other things that people talk about that can cause, perhaps cause Alzheimer's. I've listed them here. We don't know that any of these for certain will cause or prevent Alzheimer's. People are interested in what, I will say that what's bad for the heart is bad for the brain. A lot of interest in diet, and a lot of interest in staying very active, right? So you've heard all this. Let's play Sudoku. The brain's a muscle. We can strengthen it. And it's true. If you take large groups of older people and you look at people who don't have Alzheimer's and you compare them to people who do have Alzheimer's, the people without Alzheimer's are much more likely to participate in these activities. Playing bridge, playing chess, staying active, physically active. But we have no idea whether it's the actual doing the activity, playing Sudoku, that is associated with less chance of Alzheimer's. Maybe these people were born with a bigger, better brain. And that protects them against Alzheimer's. And it also helps them pursue cognitive activities. So the cognitive activities is just a sign that they were endowed with a protected brain. Does that make sense? We don't know that actually doing these things will protect you, but they don't hurt, and maybe they'll help. To my knowledge, and people have looked at this in many, many studies, to my knowledge, there's only one cognitive activity that is guaranteed to protect you against developing Alzheimer's. And I'm sure you all know what that is, right? It's attending the Leading Edge Medicine update from Barnes Jewish Foundation. So if you do that, you're good. All right, so many people have heard, and it used to be true, that we don't know for certain whether someone has Alzheimer's disease until the person dies. We take the brain and we look at the brain tissue under the microscope, just like that first Alzheimer case, and we see those brain changes that I mentioned. Well, now we don't have to rely on the autopsy. We can see those brain changes in living people. Remember I said the plaque is made up of a protein called amyloid beta? Well, we can measure the amount of amyloid beta in the spinal fluid. Spinal fluid is produced in the brain. It's very important for brain health, and it also protects the spinal cord, and we draw it out through a spinal tap, and we can look at the concentrations of brain proteins. This is the protein in the plaque, this is the protein in the tangle, and we can see whether people have the lesions of Alzheimer's in the brain. We also can do special imaging of that amyloid, and now, just in the past year, of tau, takes a PET scan, but we can see if people have the amyloid plaques. So we can tell in living people now whether they have the Alzheimer pathology. I'll illustrate that PET scan. This is with an amyloid tracer called Pittsburgh Compound B, funny name, PIB. And what happens is this tracer is developed to have a very high affinity for the amyloid in plaque. So we infuse it into the vein, gets up to the heart pumps it up to the brain, the tracer is now in the brain. If there's amyloid plaque there, it binds to it, stays there, and it's designed to give off a radio signal that the PET scan can detect. So here are two individuals. We're looking at their brains, and the brain is, the section is taken something like this, horizontal through the brain. And here's a cognitively normal person. The tracer got into the brain, looked for that amyloid plaque, didn't find any, and got washed out. In PET terms, having a blue signal means it's not positive, it's negative. Nothing was there. But here's a person with Alzheimer's. In PET signal, red means it's positive. That tracer was kept there because there's amyloid plaque and giving off lots of signal. So we can image Alzheimer's disease. But here's a cognitively normal person. And they have a PET scan that looks exactly like this PET person. So remember I said we think there's a clinically silent, pre-symptomatic stage of Alzheimer's disease. And so we would expect if this person continues to live that they'll develop Alzheimer's symptoms, and that's exactly what happened in this individual. I'm going to skip that. Okay, so Alzheimer's disease, terrible problem. Over $200 billion spent every year, only going to get worse unless we develop truly effective therapies. How are we going to develop truly effective therapies? We need to do research. So here's what the cost is in the United States. So you would think that we would devote an equal amount of funding to find truly effective therapies. In reality, this is what we do. $500 million. So unlike other terrible diseases, heart disease, cancer, HIV, AIDS, Alzheimer's disease is remarkably underfunded proportionately. Now these are terrible diseases too. They need lots of research. I wouldn't suggest anything different. I'm just saying proportionately Alzheimer's isn't getting funded. And we think, we don't know, we think that in part that's because it's a disease of largely older people, and people expect memory loss in older people. What do you expect? He's 80 years of age. They don't think about it. And it's hard to get a national spokesperson for Alzheimer's disease. We don't have a Michael J. Fox. So it's underfunded, but it is the most expensive disease in the United States. And any of you who have had personal experience with Alzheimer's, I'm talking about the public health impact. You know what the personal toll is in taking care of Alzheimer patients. We have drugs to treat Alzheimer's. May I ask anyone here associated with Pfizer or Novartis or Forest Laboratories or Janssen? Good, because they don't work very well. I don't want to say that if you were aligned with one of those companies. They're very modest in what they do. They're not cures. They're not cures. They may benefit symptoms temporarily. I use them in my practice, but they're not cures. These are drugs that we tried that we thought would be cures. Most of them target that protein amyloid that makes up the plaque. We think that initiates the Alzheimer process. But not all. Some target cholesterol or inflammation, insulin, so forth. All of them have failed to show any benefit. None of them have worked. Now, why is that? Well, maybe the drugs aren't very good. They're bad drugs. Maybe the target is wrong. Or maybe we're treating too late. So I want to come back to that preclinical Alzheimer's disease. All of those failed trials that I just showed you were given to people who already have Alzheimer's dementia. They're symptomatic with the disease. And we know at that stage, even the earliest symptomatic stage, that in certain brain regions important for memory, up to 60% of nerve cells are already gone. So by the time we give the drugs, if we wait to the dementia phase, we're treating an irreversibly damaged brain. And I'll tell you one other thing. If we have a single drug targeting amyloid, I think we're missing the boat, because by this stage there are many other processes that are going on. So we're going to need something like chemotherapy, multiple drugs trying to work together against all these processes. Now a single drug might work in this preclinical stage, which actually is the longest part of the Alzheimer process. The Alzheimer dementia stage is really the end stage of this process. So with biomarkers, measuring amyloid or imaging amyloid, we can identify cognitively normal people who have these amyloid markers or other markers in the brain before they reach a threshold where they start to kill nerve cells. So here might be an opportunity to treat with an anti-amyloid drug, but now the goal is to try to delay the onset of Alzheimer's symptoms or even prevent it. So we know that about 30% of all older adults, 70 years and older, have preclinical Alzheimer's disease. What did I say, 70%? Boy, my memory is really a problem. 30%. 30% of all healthy older people, no memory problems, have signs of preclinical Alzheimer's. We know they're at higher risk of becoming demented, but we can't tell an individual that you definitely are going to progress to symptomatic Alzheimer's, and we don't know when. Now, there is a group of individuals for whom we can answer those questions, and that comes back to those rare gene mutations that if you inherit it from your parent, we know you're going to get Alzheimer's. Even if you're asymptomatic now, you're going to get it. And we know about when you're going to develop Alzheimer's dementia because it'll be about the same age your parent did. So we can start to time secondary prevention trials. As a matter of fact, the very first one was launched here at Washington University and Barnes Jewish Hospital in December 2012. It's called the Dominantly Inherited Alzheimer Network Trials Unit. The trials unit is led by my colleague at WashU, Randy Bateman, and we're giving them asymptomatic mutation carriers, we're giving them drugs against amyloid in an effort to prevent or at least delay the onset of Alzheimer's symptoms. We're not the only ones, so after us, another gene mutation drug trial in Colombia, South America has begun. A worldwide study is looking at another drug called pioglitazone in cognitively healthy people who have increased Alzheimer's risk because of their genetic profile. And then there's a large study in the United States called the anti-amyloid treatment in asymptomatic Alzheimer's disease. So anti-amyloid in treatment in asymptomatic Alzheimer's, those 4 A's called the A4 study. So look at this. Cognitively normal people, age 65 to 85, have to have one of those amyloid PET scans. And if you have an amyloid PET scan and it's positive, there's amyloid there, even though you're still cognitively healthy, you are eligible to participate in this study. And it's a study of anti-amyloid treatment, a drug called solanezumab. If you don't have elevated amyloid in the brain, you're not eligible for the study because this treatment targets amyloid, and it'd be silly to give you a drug for which you don't have the target and expose you to possible side effects, and you're not going to get better. But the A4 study is the first study to take people without a gene mutation, just regular people who are at increased risk, we think, of becoming symptomatic because they have amyloid burden in the brain. And Erin Couture is in the back. She's standing up. There she is. And she's standing up next to Marie Meisel, also from our ADRC. You're standing up, Marie. And those two individuals will have more information and brochures about this A4 study if anyone here after the presentation is interested in that. So please see them. So the A4 study, I think I've already gone over this. There are the 4 A's, the first ever trial to prevent memory loss in older people at high risk who still are asymptomatic using an anti-amyloid antibody. Have to have an amyloid PET scan that is positive. Some people will get the active antibody, some people will get placebo, and there it is. And we're one of the sites at the Alzheimer's Disease Research Center. So there you have to have those attributes to be eligible to participate. You have to be normal, certain age, have a study partner, participate in all procedures, and see Erin. I thank you for your attention. Thanks very much.